Hello and welcome to our webinar. I'm Sarah Ide and I'm one of the Dento-Legal Advisers at the DDU. I'm joined by Jodie Carr, who as a former CQC inspector is going to share her inside knowledge and help you to feel confident and prepared for your next CQC inspection. So here's the aim and objectives, and in summary, we're hoping to enhance your understanding of the CQC inspection process. I'm now going to hand over to Jodie.
Thank you very much, Sarah. Hi, everybody. My name is Jodie Carr. I'm a former CQC operations manager. I used to lead a team of inspectors in the London region who inspected dental practices. Prior to this, I was a dental inspector myself. And prior to that, I was actually a dental practice manager of multiple sites. So I have actually been inspected twice, in fact. I have been the inspector and I've also been the person that makes the enforcement decisions. So I'm really hoping today I can share my knowledge with you, give you a bit of confidence and hopefully show you that the CQC shouldn't be super scary. So the agenda for today, we're going to talk through when and why you might be selected for an inspection, and this is a very, very common question that is asked. Insights from myself, any kind of hints and tips that I can give you, really what inspectors actually look for, how you can share compliance with the whole team, and any kind of recent themes from inspections, because I'm hoping that will really help you, and some practical tips to stay inspection ready all year round. And hopefully at the end we've got some time for questions and answers, but there's quite a lot I want to get through today.
So we'd like you to vote in this poll to start off with. And the question we're asking is, do you know how many practices are selected for a routine inspection each year? So please do choose the percentage that you think is right. You've got 30 seconds, so there's no hurry. Whilst we're waiting for you to vote, Jodie's going to carry on with some helpful tips for you.
Perfect. Thank you very much, Sarah. So what we mean by a routine inspection is where all of the key questions are reviewed. So the safe, caring, effective, responsive, and well-led. And it'll be very interesting to see what everybody puts as their views. So I'll just give that a couple more seconds before I move on to the next slide. So we'll just go to the next slide now. Perfect. So excellent. So it appears that over half of you are aware that 10% of practices get inspected each year, and these are the routine inspections. So I'll just move on to the next slide now. So there's four kind of main types of inspections that the CQC conduct, and they are risk, routine, a follow-up, and a registration. And if we move across to the next slide now, so thinking about a routine inspection, so as I said, this is where all of the key questions are looked at. Even with the single assessment framework, 10% of practices are still inspected. That hasn't changed. So if your last inspection was around 2014, 15, 2016, it's very likely that you're going to be inspected within the next year or two. And the reason why I say 2014, 15 is because the CQC are a little behind in certain areas. It's worth noting that with the announced inspections, you tend to get a 2-week notice period. Sometimes it's a little longer if the inspector's on holiday, but usually it's a 2-week notice period. And it's really important with these routine inspections that you don't ask to change the inspection unless it's exceptional circumstances. So by exceptional circumstances, I'm thinking of a bereavement, potential bereavement, for an example. And the reason why is, as an inspector, if somebody is getting in touch to say, we can't make that inspection because somebody is on holiday, really that's a great time for an inspector to come out and visit the practice and see how your practice is running without that key person. So that isn't always a reason to cancel. And it's a bit of a red flag. It makes me think, why do you not want us to come out and inspect the practice? The second type is a follow-up inspection. So that is usually following some sort of enforcement or action plan request that you've had. So you will be aware of when they're coming back, because you will notice that on the enforcement notice with the date of when you need to comply, or the action plan request where you will put the date of where you suggest that you would have made those changes. So you would know roughly when they're coming back for the follow-up, and any registration changes. So if you've just purchased a new practice, any new registration, that would likely prompt a visit from the registration team. This question always gets asked. Why would they come out unannounced? What would constitute an unannounced inspection? So this is what I would deem as a risk inspection. So every day CQC has, actual fact is for 2023, 2024, 195,000 pieces of information of concern came through to CQC. And of that information of concern, 30,000 were safeguarding and 15,000 were speaking up cases, whistleblowing cases. So when that information comes through to the CQC, it is categorized and prioritized, and the inspector will then review what information they hold and what information that says. So for example, if it was a safeguarding that had come through from the local authority, they may deem that they may need to go out for an inspection. They may deem that they need to receive kind of further information from the local authority. For example, if it's from a patient, they may look to contact that patient for some further information. So really that information coming through doesn't necessarily mean, right, as an inspector, I'm going to go out and inspect. It forms part of the judgment process. So if it was something that was high risk, I would start off with a decision review as an inspector, which usually involves an operations manager, and I would start to review the information that I held on that practice and the information that was given to me. So for example, if it was a safeguarding or a whistleblowing, and the whistleblowing stated that the practice had no fire equipment or no emergency equipment and nobody was trained, that would be quite risky for me. So I would look to see what information we hold and whether we needed to cross the threshold and announce an inspection or unannounced inspection. Now with risk, it's usually an unannounced inspection. You want to see what's really happening on the ground on that day. You don't necessarily have to go out for an inspection. You could gain assurances other ways. So for example, if some information of concern came through and it was regarding a complaint, I could ring up the practice and ask for their opinion or ask them to provide their complaints policy, for example. So it doesn't always mean that I'll go out as an inspector and inspect the practice, but it's worth noting that the majority of time with risk, it would likely be an unannounced inspection. There are other avenues, such as potential referrals to the GDC or ACAS. A lot of the time, whistleblowing can be areas that aren't actually within the CQC remit. So it could be signposting that person to, for example, ACAS. And the reason why you're carrying out an unannounced inspection ultimately is that there is potentially a risk to patients, staff, and the public. But it really, really does depend on what information comes through.
So we've got another poll for you here, just to keep you on your toes. So we want you to vote on this. Of the inspections that were unannounced in the past 6 months, how many do you think were not compliant? So please do vote in the boxes. And again, you've got about 30 seconds. So I'll just hand back over to Jodie whilst you're doing that.
Thank you, Sarah. So yes, we're thinking about unannounced inspections. So the practice do not know that the CQC are coming. And from personal experience, any unannounced inspection that I carried out, of every single one that I carried out, nobody actually expected me to turn up that day. If you think tomorrow on your drive to work, it's very, very unlikely that you'd expect to see CQC or even think that you were expecting to see CQC. I'm just going to move across to the next slide now. So really interesting. So 60% of you on the call believe that 25% were not compliant, and another 25%, oh, it's got shot up now, sorry, to 60%, not 25% not compliant, and 50% not compliant. Around a quarter of you feel that way, with only 1.4% of you believing that 100% were not compliant. So quite interestingly, 100% of practices that were inspected unannounced by the CQC all resulted in enforcement. So if there's one thing that we can take away from today, is that CQC inspections really can happen at any time. Ongoing compliance is essential. It's a new year, January, so maybe a new habit to get that team engaged and not wait for the call and to really look at your compliance. So thinking about now, I've decided, let's use me as an example, as an inspector, I've decided I'm going to go out to this practice and I'm going to inspect this practice. Now this could be a routine inspection or an unannounced inspection. So the first thing I'm going to do is review the information that's actually available. So the practice's digital footprint. It's very easy for me to look at. I can just pop on a search engine and I can look at the practice website. Google Earth, which I'll talk about in a second, reviews, and the social media of the dental practice. So keeping with Google Earth and a real life scenario here, a member of the public contacted the CQC to complain about some clinical waste bins that were outside of the practice. I'd actually already planned to inspect this practice, so I had a look at the information that we had, and I popped on Google Earth just to see where this practice was. Now, Google Earth can give quite a lot of information away, and actually on this occasion the clinical waste bin was on Google Earth with all the clinical waste bags hanging outside of the bin, and the date of the Google Earth was actually a year ago. So it just went to show that actually there really was an issue with this practice. Now, I'm not saying that you need to check your Google Earth every day, that's a bit overkill, but it's worth having a look at what your Google Earth looks like today, and also just thinking about the external side of your premises. Are you making sure that your bins are locked away? Are they chained securely so no one can take away your clinical waste? You know, is it well kept outside, and are you accessible? These are the types of things that I would look at as an inspector on Google Earth. The next thing I would look at is your website. So firstly, I'll check that, do you have one? And if you do have one, is it up to date? So are you keeping it up to date? Does it have information about whether you're accepting new patients? This is good for the key question of responsive. Does it have an up-to-date price list and treatment list? And you really need to make sure that accurately reflects what you're offering in practice. So for example, many practices have on their price list and treatment list that they offer sedation, but as an inspector, you go into the practice, they're no longer offering sedation. So make sure that you keep that practice price list and treatment list up to date. If you've got a website, make sure that your complaints policy is on there. It should be on there, and a patient should be able to easily find it. So often when you go onto a website, it's in very, very small details at the bottom. Ideally, you want a link to the CQC website so that patients can look at the latest report that you have. And if you haven't got this, this is one key tip that I would love to share, is consider adding some accessibility information. Nowadays with AI, a lot of the time AI can kind of scrape websites, and if you are a wheelchair user, it would be fantastic to pop in the system, where is a wheelchair accessible practice? And often as an inspector, I would check this all of the time as well. And 9 times out of 10, the practice would never have this on their website. When you spoke to patients, they would often say, one patient in particular told me they had rang, apologies, skipped a slide. One patient told me they had rang 20 practices to find out if they were accessible. It's just a lot of time consuming. If you can pop it on a website, it just would be a fantastic offering for patients. Now I'll move to the correct slide. So the next thing that I would look at is online reviews. So I would look to see really here, have you read and responded to them? So CQC are well aware that online reviews are not verified. They are aware of that. I would look at kind of Google reviews, Trustpilot reviews, NHS choices, but being very aware that they're not verified. But really as an inspector, what I'm looking for here is, are there any themes? Is there anything that's really sticking out that the practice needs to start reviewing? Has the practice acknowledged them and invited the respondent to actually contact them and talk about it? Remember, if you are responding to them, you must maintain patient confidentiality, and also just be aware of your own GDC standards. So you should be responding to them appropriately. I will also look at social media. This is becoming more and more common with dental practices. They're following the latest TikTok trend or the latest Instagram trend, and often without realizing they're actually breaching their own infection control procedures or their own GDPR policies. So one in particular, we'd had some information of concern come through, had a look at their social media, and in the background they had their day list up for that day with all of the patient identifiable information. So it really is worth considering what you are putting out there on social media, making sure you're being very aware of your own policies. Thinking around kind of good press or bad press. So I would again use a search engine, type in the practice and see what comes up. Sometimes good press would come up, which would be fantastic, often where practices have gone out and used their own initiative to visit care homes or nursing homes or helped the homeless, but all of this would be great for evidence in the caring key question, for example, or responsive key question. And sometimes there was bad press, and really with the bad press I'm thinking, okay, this could aid some of our conversations when I go into the practice. Have you done, for example, if you have had some bad press, have you done a significant event? Have you got an action plan? You know, what have you done to improve since then? I'm just going to quickly take a glass of water.
I just wanted to mention, Jodie, that we have a press office at the DDU. So if you're contacted for comment or approached by a journalist, don't say anything, but do contact us and we can put you in touch with the press office.
Perfect. Thank you, Sarah. So after I've reviewed the information, it's likely that I'll give your practice a call, or I will send an email to your practice as an inspector. So what you really want to make sure is that your registered manager and your nominated individual details are up to date, because if I'm going to send an email, make sure that it's the correct email. You don't want to miss that email. Now, many inspectors will follow up after the email if they've not heard back from you with a phone call just to make sure that you've got it. But you don't really want to lose those crucial days where you could be preparing. So just make sure that you keep that up to date. In that email will be a provider information request, or a PIR, and really this forms quite a lot of important information that saves time on the day, but is also where the inspector will cross-check on the day. So it's crucial that you complete accurate information. So for example, on one of them, it will be a Word document that will ask you to put the latest dates of when your X-ray machine was serviced, or the latest date of your risk assessment. So if you input the wrong date, you just want to make sure it's the right date, because as an inspector I will come in and cross-check that. So just make sure it's accurate, be honest, because again I'll be cross-checking as an inspector, and just make sure that you complete it within the time frame. Again, it can look at a little bit of a red flag if you're delayed with it. There may be circumstances which is an adequate reason why you might be delayed, and that won't stop the inspection happening. So on the day it would just take slightly longer because the inspector will fill that out with you in person. So if you really can't, don't worry, but just keep that communication open and contact your inspector. It's also worth checking your statement of purpose and updating that at this time before sending it back to the inspector, to just make sure that it accurately reflects your processes of what you have in place. So this here is kind of a mock-up that I've done. So I'm thinking of a little bit, slightly like a role play scenario here. So thinking that this practice has had their announcement in December. They're being inspected in January, and this section here is part of the training spreadsheet that you would be asked to fill out as a practice manager. And I'm actually going to put you on the spot here, Sarah, but is there anything when you look at this, and I'm very well aware that it might be on a very small screen to people that are watching on their phones, but is there anything on here that when you look at it you think, oh, that looks great, Sarah, or do you think actually there might be a few red flags here?
Well, on first glance, it looks pretty good. It's all filled in. All the boxes are filled in, so they've, done that. But then when I look a bit more closely, I can see the principal hasn't done medical emergencies for over a year. And I'm guessing that to say not applicable for a trainee dental nurse isn't really appropriate.
Absolutely. So on first glances, everything, like I said, is filled out. It's all filled out. It looks okay on first glance, but when you really look into it, there's actually quite a lot of red flags with this one here. So focusing at the moment on the medical emergencies, the basic life support CPR training, absolutely correct, Sarah. We would expect that to be completed annually. So my first kind of red flag when looking at this is the principal dentist who last had it completed in November 2024. Now it looks like this practice all completed together because everybody else completed it in November. So it's likely that the principal dentist was probably away. That's not a great excuse though. So we would expect at CQC, the CQC inspector would expect that they would look for another appropriate course. So thinking around a practice that has other practices around them, you can give them a call and see if there is another course that you could join on, or you could look, there's several courses online, but you need to risk assess whether you should be doing an online course. Now, ideally, everyone should be doing hands-on course, and that is exactly what the Research Council guidelines state, but it really depends on the situation. For example, clinical staff should be doing hands-on training. A receptionist might be deemed appropriate for, as a non-clinical, to watch an interactive film, for example. You need to risk assess and assure yourselves that your staff are trained, and you need to review what you deem appropriate. Not applicable is absolutely correct, Sarah. We would expect a trainee dental nurse to have completed some training, and that should be part of their induction process as well. So just remember as well that all primary dental care staff should be trained. They should be familiar with the location of the resuscitation equipment and the medical emergencies equipment, and they should be kept updated at least annually. And a top tip is to carry out some scenario training. There's nothing worse than a medical emergency actually happening. So if you're prepared for it, it's far better. So now I'm just looking at the safeguarding section. And here, my red flag, which you probably can't see on a very small screen, but actually the date here is the 1st of January, which would have been New Year's Day. And it's very unlikely that all of the practice carried out safeguarding training on New Year's Day. And this does happen with practices where they pop in Christmas Day, or I'm not saying that not everybody does do some training on Christmas Day or their birthday, for example, but you never know. So I can't say never, but it's just worth noting that you are putting accurate dates. You're not forcing your staff to work on New Year's Day to get some safeguarding training completed. And the date with everybody completing it in January makes me wonder as an inspector, okay, have they done this training in January and they haven't done it before? Now, again, that's very assumptuous. They could well be their annual dates that they renew it, but it probably is a bit unlikely. And usually you'll be able to see on here all of the dates in January. That being said, as an inspector, I would much rather the practice have done it in January than not at all. So I would much rather that they have taken the action that they needed, saw that it was due, and did the training. It's worth here mentioning that you need to look at the intercollegiate guidance and deem which level is appropriate for your team members and make sure that they are on an appropriate course. So for example here, the trainee dental nurse, just because they're a trainee dental nurse, you often hear, oh, it's covered on the course. Often it isn't. So they need to have safeguarding training as part of their induction, and you need to assure yourself that if it is part of the course, that it is an adequate training and it's to the adequate level. So summarising the PIR, so the provider information request here, make sure that you complete all of the training on the spreadsheet. So for any that aren't completed, you probably want to risk assess them, prioritize which ones you're going to do and create an action plan, and also think about what you're going to say to that inspector why it wasn't completed. It doesn't show that you've got good oversight of training if not everybody has completed their training. You will, as a practice manager, remember very, very well that it's very difficult to get everybody's training completed, especially if you have new staff members or staff members on maternity leave, for example. So pop that in your action plan and be realistic with your action plan. You can't expect somebody to come back off maternity leave and spend the whole 2 days doing training. You know, just be realistic here with your timelines. Any gaps that you have in servicing of equipment, so they will come up on the provider information request as well. Any gaps, I'd say it's wise to use that 2 weeks to get them booked in. And any dates that are missing, so for example a fire risk assessment, you need to consider who's done them, but I'll talk about that in a lot more detail later on. And you need to consider if you need a fire external risk assessment. Think about the levels of training. So going back to that spreadsheet, think about whether you need to refresh yourselves with the safeguarding intercollegiate guidance, whether you have a CBCT machine and whether staff need level 1 or level 2 training. If you're a sedation practice, do you need ILS training? Yes. So ILS training or basic life support with airway management is what is needed if you're carrying out sedation. So again, familiarise yourself with those guidelines. So thinking about now when the inspector arrives. So remember, the inspection team tends to be an inspector and a specialist advisor who has a clinical background. The specialist advisor tends to look at more of the infection control, speak with the clinical team members and review clinicians' notes. Not all of that, but that's the majority of their focus. And the inspector will tend to look at more of the governance side, speaking with patients, the reception team and the practice manager. Be prepared. Please let your reception team know that CQC are coming. I've been to practices before where I've turned up and not unannounced. Everyone's known about it except the reception team, and they say, "Who are you? You can't come in." Remember, CQC do have a warrant card. They can come into your practice unannounced, but even when it's announced, it's not a great impression if your reception team don't know who CQC are. Make sure that you follow your visitor's process. So, for example, if your fire process states that you have a visitor's book when people come in, so that could be CQC, that could be somebody servicing your equipment, for example. Make sure that you hand that visitor's book over and you follow the same process. Often people will think CQC and just panic sets in, but make sure you follow that process. And often you will look at that visitor's book and you'll be the only visitor they've ever had in 5 years, which also as an inspector doesn't give me a great idea that you're following your own fire procedure very well if you've not really been given that visitor's book out. So have a look at that visitor's book. It's worth noting to the inspector and the specialist advisor if you've got any fire procedures that day. So are you carrying out a fire drill? Where is the fire exit, for example? Now, I've got a picture of a lovely spread of croissants and tea and biscuits, etc. That bribery is definitely not what I'm saying here, but a tea and coffee and a biscuit, it just breaks down those barriers. Often the inspectors travelled and the specialist advisors travelled quite far. It's just helpful to have a cup of tea and really humanise yourself, actually. So let them know if you've had any issues, let them know what's going on at your practice, really humanise yourself. And another important thing I would say is if you have any staff members who are particularly nervous, it's totally expected to be nervous. Myself, when I had my inspection, I think I cried in the morning because I was absolutely petrified. So they do know, and I can say firsthand, I do know how nerve-wracking it is. Make sure you tell them if you're nervous, or if you've got any particular staff member that has, for example, additional needs, hard of hearing or struggling, just let the inspection team know. It can really help with the flow of inspection. So there's quite a busy slide here because actually the next stage of inspection is, so I've got some information on your practice. You've sent me your provider information request. I've come into the practice, and now a crucial part of the inspection process is actually taking a look round. Now this usually happens within the first half an hour of arriving at the practice. Usually a practice manager or the practice principal will show you around the practice, and these are just some of the things. I won't go into all of them, but just a lot of the things that I would be looking at as an inspector and a specialist advisor. Is it accessible? So if I am a wheelchair user, can I get into the practice? And many times I've been caught out where they've said they're accessible, but actually there is a step into the practice. So really think about, is your practice accessible? Is it clean? Not just your surgeries. When I walk around the practice and I touch the skirting boards or touch around the sides, is the general practice fairly clean? Are there any hazards or risks? So often you would see an electric socket with loads of plugs all coming out of it. So just think about, is that a fire hazard? Does that look okay? Probably not. Do fire exits open? Quite an eye-opening story here, but often you will go into the practice and see if where the fire exits lead you. You know the green signs that have the arrows? So you would follow the green signs with the arrows to see where that would lead me. Even though reception have told me this is the main fire exit, often around the practice there'll be the fire exit signs. I would follow them. One practice I went to, I followed the fire exit sign, went to the fire exit, which was locked, asked the practice to open. So obviously this is the first red flag I've got here. This fire exit is locked, not great. They opened that one to another locked door, to another locked door, to another locked door. It was 4 locked doors in total. Really not okay. What does the environment feel like? What does it kind of smell like? Is there any places that are out of bounds to patients? And if it is out of bounds, is it exactly that? Another practice I went to, I stepped upstairs, it said out of bounds, opened the door, which was able to be opened, huge gaping hole into the reception area below, and there was just a sheet covering it. You just wouldn't believe your own eyes. So make sure that if there is any areas that are out of bounds, that patients cannot access those areas. And is there any patient identifiable information on show? So for example, if you've got your computer, are you making sure that you lock your screens? If you've got a day list, are you turning it around? Medications that patients can't access them, and that you just have the appropriate signage around, so your fire exits, where the medical emergency is, and if you have CCTV, that you've got the appropriate signage. So I'm thinking around here some red flags that I might see when I'm on that tour. So I've already spoken about a few of them, but really what I'm actually doing is seeing if staff are hiding. Sometimes you'll go to a practice and staff have booked the day off. Everybody's off that day. That is also not a great sign. Nobody kind of willing to talk, a lack of honesty, staff questionnaires not completed. It really does feel like a closed culture, and you can actually feel it. As an inspector, when you walk around, you really can see the difference between a practice that is a cohesive team, all involved and kind of happy really for you to be there, in comparison to a practice that are pretty much hiding. And I have been in situations where people have literally hidden behind a door to get rid of me. So I do understand that it is quite nerve-wracking, but it can really create quite a red flag. And thinking about green flags, what was great to see when I was inspecting is when you walk around that practice and throughout the day, that people are taking notes, and where they can make an improvement, that they actually make the improvement there and then. So for example, medical emergency equipment, say one of the items is expired. If you can actually order that there and then, it just shows that you are a responsive practice, that the risk is actually mitigated, that you are kind of planning ahead of when you can make these improvements. You can feel when a practice is a learning culture as well, that staff are open, and you can just feel that good communication with patients and staff. Now, often you might notice on reports where there is very small minor issues found on inspections, and there is often minor issues found on inspections. No practice is 100% perfect. Where there is, a lot of the reports will say action was taken immediately. And these are those providers that are being really responsive on the day. They've got their notes, they're making those actions. So really, it can really help you. I always get asked this, what are the kind of questions that an inspector might ask? And I would be here all day if I've told you them all. But on average, the main questions that I want you to take away from here, and the main kind of points really, is if I was an inspector, I wanted to test if the systems and processes in your practice were embedded, I would simply ask the newest team member. That way I can see how good your induction process is. How to test if staff know how to use the medical emergency equipment. Often the specialist advisor will actually ask the trainee staff member, again, to make sure that your induction process is there. And be prepared to show inspectors. So when we're talking about what do you do for infection control, it's very often the specialist advisor will ask the dental nurse to show them exactly how they decontaminate the instruments, exactly how you do your fire checks, which I'll talk about a bit later because I've got some good stories there as well, and where the waste is. So it's just because it's raining doesn't mean that I wouldn't go out and have a look at where the waste is. So that's not a get out clause if it is raining. So I'm thinking around now how to involve the whole team. So often, and again, being an ex-practice manager myself, I know the burden that you can feel preparing for an inspection and just ongoing compliance in general. And it's just so crucial that if you could share the compliance with the whole team, it really does demonstrate an excellent practice. It will boost staff confidence. It really reduces anxiety and demonstrates a strong culture on the day. It just fosters a culture of compliance and improvement, and you're just less likely to have gaps because people who are aware of compliance will be able to identify those shortfalls very quickly. It builds a really resilient team, so less reliant on one person. It really reduces burnout on that one person. And remember, if that practice manager is away, it won't matter because compliance is everybody's responsibility. And lot of the inspections that have been carried out recently, a lot of the breaches are around Regulation 17, good governance, which falls under well-led. So again, being a well-led practice and involving the whole team really is crucial. So how to get the whole team involved? And this is something that I would love for you to take from today. Many times as an inspector, I would go and speak to reception. First of all, they'd be shocked that I'm speaking to them. And secondly, they would respond with, I don't know, I'm just a receptionist. And if there's anything that I want you to take from today, if there's any receptionists on the call, you're not just a receptionist, and your reception team are not just a receptionist. They're actually crucial and really valuable members of your team. Their expertise is fantastic. And as an inspector, they actually have quite a lot of questions asked to them. And I'll go through this now and how you can involve them. So as an inspector, the first thing I would ask reception is, how do you get an appointment at your practice? You know, how do you manage your emergencies? How quickly can I have an appointment? What do you do with new patients? Those kind of questions will go to reception. So being aware of what their responsibility is there. So around kind of emergency patients, do they triage emergency patients? You know, what is the process here? Safeguarding, very often receptionists will answer that telephone call and be able to hear what's going on in the background, for instance. So they may even be able to trigger any kind of safeguarding concerns from listening on a phone call. Remember, they're the ones that answer the phone call for patients that was not brought. So children that was not brought for their appointments. It's mostly reception teams that will know those patients that are forever kind of was not brought, and they should be aware of the was not brought procedure. Sepsis, thinking around emergency patients, who do they contact? Reception team. Reception team must be aware of the signs and symptoms of sepsis. And instead of saying, I'll book you an appointment next week, they should really be saying, okay, we've got some issues here. I should probably be signposting you to A&E, for example. So they really need to be aware of the sepsis process and sepsis signs and symptoms. Complaints. Very often, a patient won't speak to you about a complaint as a dentist, for example, but they'll quite happily go out to reception and talk about it and complain. Or any feedback, they often hear that in the waiting rooms. So it's really crucial to involve them in all of these processes that I've got on here, and thinking around kind of fire checks and environment. Often reception team sometimes will be able to stretch their legs and have a look around, and also be in charge of quite a few environments at the practice. So thinking of the waiting area and reception, for example. So it's worth getting them involved in the fire checks too, and anything in the environment and the induction as well. Same for dental nurses. Often they will also shy away from the inspection team, but actually, let's be honest, how many dentists go out and decontaminate their own instruments? Probably very rare. So it's usually the dental nurse team that will carry that out. So making sure that they are trained in infection control and able to answer any kind of infection control questions. And those are usually around how do you decontaminate your instruments? How do you package your instruments? How often do you change those heavy duty gloves, which, may I add, should be weekly? They can be involved with your radiography processes, Legionella, for example, so running the low use taps and checking the water temperatures, fire checks, record keeping, complaints, so on, so on. So just make sure that you get them involved in the process as well. And the same for your associates and your dental care professionals, DCPs. So thinking around peer support, DCPs, associates would be great for peer support. Can they be involved in any kind of appraisals as well that you do at your practice? Thinking about a freedom to speak up guardian potentially would be a really good idea. A lot of practices sometimes have potentially a closed culture, being maybe a husband and wife or family member setup. So if you've got an associate that isn't part of that, they probably would make a really good freedom to speak up guardian. So think about how you can utilize their skills with record keeping, radiography audits, and also remember, if you are an associate or a kind of an external clinician that comes in, thinking about like locums, you should assure yourself that the equipment that you're using is clean, that it's in good working order, and that your stock that you use is in date. So I'm just going to summarize as much as I can there. So make sure that you are honest. Your version will be corroborated with others. I do have a fantastic story about a smoke alarm, and this smoke alarm was very, very high up on at the top of some stairs, and I asked the person that said that they did the checks how they actually got up there. Do they have a ladder? How did they check their weekly smoke alarm? And they said that they used a pole. I said, okay, can you show me? Where's the pole? Let's have a look, see how we could do it. They couldn't produce a pole, so they said, it wasn't me, it's somebody else. I asked the other person, how do you check it? They said they used a feather duster. They pulled out this feather duster, and there was no way that feather duster was going to reach up there. And it wasn't until then that they said, okay, we haven't checked it in years. So really just make sure that you're honest, that actually your version will be corroborated. Train all your staff on how to operate the medical emergency equipment and the reasons why you need to use it. So why do you need to use GTN spray? Why do you need to use an EpiPen? Carry out fire drills. So often fire drills are not carried out at dental practices. Make sure you carry them out and you note them down. So who attended, how long it took, for example. All of your staff meetings, note them down, share them with team members who were not there. Doesn't necessarily have to be a written form. You could email out the notes, for example, or if you have maybe a WhatsApp group, you could pop them on there, just as long as you're sharing any key information that they may have missed. Remove your cleaning products. So often bleach will be in the toilet, so you need to follow your COSH procedures there. Make sure that anything that such as bleach is removed. Risk assess anything that you identify as missing. So I'm thinking of DBS checks here, but I am going to go into that in a bit more detail later. Implement that process for changing the heavy duty gloves. So thinking around making sure that you change them weekly. It doesn't have to be a tick box. You could do something very simple, such as putting the date on the inside of the heavy duty gloves, for example. Secure your waste. And do not pre-stamp your prescriptions. So make sure that you improve the security of the prescription pads. And I can just see some questions coming through. So I'm just going to pause there and just going to answer this one. So for a non-clinical member of staff to make a decision regarding sepsis, what I would recommend actually is that the reception team have some sepsis posters. So they have the, if you Google the sepsis posters for dental receptionist, just on Google engine, they will come up, and often they will give you the signs and symptoms. If somebody is telling you that they can't breathe, that they are struggling for breath, that they feel like they're going to die, really they need to be calling 999. And either keeping them on the phone and somebody else call 999, but they should be following their sepsis process. So whatever process you have in practice, and obviously that should definitely be in conversation with a clinician there. So no, it's not necessarily for a receptionist to make that call, but really a receptionist should be making that call if somebody is displaying symptoms that they can't breathe, for example. We wouldn't expect them to delay that care for them. I'm just going to move on now. I'm just going to take a quick pause, sorry. I think I've just answered another question that came up with the sepsis training. So I'm now going to move on to the themes from inspections. So I often look at reports every quarter, and I tend to look at around 50 reports that have been published. So for October, it was 19% of practices were not compliant. So that means they've received some type of enforcement, whether that be warning notices and above or an action plan request. And it was around 8% in December that were not compliant, and going back to July it was around 25%. Now for December, all of the breaches of regulation were for Regulation 17, good governance, so thinking of oversight and leadership, and they were all action plan requests. So what I'm going through now is the most common themes that come up in inspections. So this one here, for example, of 28% of reports, it mentioned fire. So these themes that I've kind of picked out, just because a practice has become compliant doesn't mean that there isn't information in that report of suggestions. In the old version, they would have been called shoulds, but they now are just in the body of the text. And these are the most common things that come up. And I thought with 28% of reports saying this, you've probably heard this many times before about fire, but clearly there's still some improvements to be made with 28% of practices in December having this. So thinking around fire, have you got a fire risk assessment? Was it carried out by a competent person? So CQC are not there to assess your competency. However, they will ask, for example, what legislation applies, how do you identify your ignition sources, or what have you used to determine how many fire extinguishers you've had, what is a PEEP, for example. And if you don't know the answers to these questions and you've carried out that fire risk assessment yourself, it doesn't give confidence in the CQC that you're a competent person. So you don't necessarily have to have an external fire risk assessment, but if you are not deeming yourself to be a competent person, then you probably should have. Just because you have an external fire risk assessment doesn't mean that you're compliant, because often on an external fire risk assessment and an internal fire risk assessment, there will be many actions that you need to review, and some of those will be high risk. Many times practices will just ignore this, but you must make sure that you review the actions that are in the fire risk assessment and create an action plan. It's not good enough having a high risk and saying, I'll review that in 3 years' time. You need to have an appropriate timescale. Fire equipment checks, this comes up all of the time. So there should be monthly visual fire extinguisher checks. So that's just a quick look around the practice, visually at them. Have they been tampered with, for example, especially in the reception waiting areas where children can get hold of them. So just make sure that you are checking monthly, that you check your smoke and fire alarms at least weekly, and that you check your emergency lighting monthly. Fire equipment not serviced at regular intervals. This will depend on the manufacturer's instructions, but often the fire alarms tend to be needing to be serviced 6 months. So make sure that you follow your manufacturer's instructions. And the electrical installation condition report, this is mentioned a lot in practices at the moment, that the certificate isn't present. And if it is present, you need to review if it was a pass or a fail. And this must be completed every 5 years. And just another helpful tip that I actually went to a practice and saw, they had what they called Find Bob. And what they did in their fire drills was they drew a person and they hid it around the practice in different rooms. And it was just super helpful for the practice team to get used to sweeping that building. It made it quite interactive, and it was just a great little tip that I thought I would share. Audits, this comes up a lot of the time, and in fact in December it came up 16% of the time. So mandatory audits that were not completed at the required schedules, or audits that had no learning outcomes and were not used to drive improvement. So the essential audits that you need to have are an infection control audit, which must be completed every 6 months. Please don't think you have to be 100% of the time. It needs to accurately reflect what is going on in that practice. So often practices will say, they're 100%, there's nothing going on here, but actually when you look below the surface, there is maybe a nail brush, for example, or the heavy duty gloves don't have, they haven't been changed, or many reasons. So make sure that you are accurate with what's going on, and you use the audits to drive improvement. So the CQC will want to see the audit data collection. So for example, a radiography audit, they'll want to see that you've got the data, the amount of x-rays, for example, that have been taken, that you've assessed it, and you've got an action plan, and that actually you are using these audits to drive improvement, not just a tick box exercise. So the essential audits are infection control, radiography, which should be at least every 6 months, and you need to really assess how many x-rays taken. Often people say it has to be 100, it has to be 100. Not necessarily. If you're a small practice, say a single-handed provider, often not taking x-rays, for example, you wouldn't have to do 100. So you need to be sensible with your how many you're taking, really. Sample size, can't get my words out, sorry about that. Sample size. The accessibility audit, this is an annual audit that all organisations providing services to the public must audit their facilities. Now, these audits aren't mandatory. However, they are recommended, and they are always mentioned in CQC reports when they're not present. So think about your antimicrobial audit. So if you haven't done one, it's probably worth having an antimicrobial audit and record keeping audit, especially thinking around kind of consent, risk assessments, for example, in your so caries risk assessment. just as an example, a recall period. So just looking through your record keeping audit. And if you haven't done one, it's probably worth doing one. And I would suggest that you don't do your own record keeping audit. So it's probably worth, again, sharing that with the rest of the team. Legionella, I'm not a Legionella expert, nor is any other CQC inspector, but it does come up a lot of the time. And Legionella risk assessments often actually are completed by external companies in dental practices, but often again the actions have not been reviewed. The temperatures are recorded but not achieving the required levels. So for example, a practice will have temperatures of 30 for their cold water tap when really they should be below 20, and as an inspector you're looking to see when it has reached 30, what have you done about it? And often practices, it'll have been reaching 30 for about 6 months, but no one's actually done anything about it because they're not actually assured on their own processes. Make sure that you are following your processes that you have around Legionella and temperature checking and following weekly flushing and any dental unit water lines that you are managing them appropriately. So flushing them regularly, for example. I could go on about this for a long time, but I'm just very conscious on the time. I'm just going to move across to the next slide for medical emergencies. This also comes up a lot of the time. Most of the time it's more around the oversight of the checking. So thinking about who actually checks your medical emergency equipment, how often are they being checked? So as a minimum, they should be checked weekly. Ideally, thinking about your oxygen and your AED, you want to be doing that daily. Think around your glucagon. If you're not storing that in the fridge, you must follow the manufacturer's instructions because it is likely it will say to reduce the expiry by 6 months, but you must follow the manufacturer's instructions on the glucagon. And make sure that you familiarise your staff with how to use the drugs and equipment. And if you do not follow the BNF or the Research Council guidelines, you need to risk assess yourself as to why you're not carrying that, why you're not stocking that drug. Finally, worth mentioning to do some medical emergency scenario training as well. And next one is recruitment. Sorry, I'm trying to fly through this because I can see quite a lot of questions coming through. So I'm just conscious I want to answer your questions as well. Recruitment comes up all of the time, I would say, in many practices. And again, it's mentioned in 15% of reports. So often it is around a DBS not being conducted at the time of employment. If you haven't got a DBS at the time of employment, you need to get it as close to the employment date as possible and risk assess in place whilst awaiting. It is very unlikely that it would be sufficient for a clinical staff member to be carrying out clinical duties without a risk assessment in place. So thinking of a dentist. But for example, a receptionist, you may choose to supervise them and then you could put a risk assessment in place. Make sure that you have got references. Again, this is another common area where you can't get 2 references, for example. So make sure that you risk assess this in place. Hepatitis B, risk assessments if they've not completed their full, GDC checks and right to work checks. Make sure that you're checking those regularly and that you have a process that you can see that they've been checked regularly. No, you do not need a Legionella external risk assessment if you deem yourself to be a competent enough person. So going back to the same as the fire, if you deem yourself and you feel confident enough to be able to, if the worst was to happen and there was a Legionella outbreak, would you be confident enough to answer the types of questions that you would be asked? Training. So thinking around the oversight of training, this was mentioned in 15% of reports. So again, where mandatory training hasn't been completed, often that is safeguarding training. So go back to the intercollegiate guidance and look at the level. Fire training, everybody should have fire training. Infection control training, make sure that everybody's got infection control training, and if you've got lead areas, that they do the appropriate training for those lead areas. And learning disability and autism training, which I'm expected to probably have a lot of questions on this. So I can probably see this is coming through already, but what I will say about that is the Health and Social Care Act has introduced the legal requirement that all CQC registered providers must ensure staff receive learning disability and autism training, which could be the Oliver McGowan training. Now, level 1 can be completed online, should be completed online by everybody, and it tends to be free of charge, or if you have a compliance system, for example, it could be part of that compliance system or through the e-learning for healthcare, for an example. Level 2, CQC understands that access to this is very limited at the moment, and it is likely that more availability of courses will come out in 2026. So they are taking quite a pragmatic approach, but at the moment they would expect a level 1 minimum and level 2 to be undertaken, but they are aware of the difficulties that you've got about finding training courses at the moment. You just need to basically assure yourself that all of your staff working in your practice have the required adequate training. And think about, even if they are, say, a self-employed associate that comes into the practice, make sure that you have had oversight of their training, that you can confidently say that they have received all of their training. So it's worth, I know what it's like, practice manager, asking for those CPD certificates, but make sure that you do. It's really crucial. So just to summarize, lead areas should have training. So for example, infection control should have some adequate training for lead areas. Legionella lead should have adequate training. And if you're a sedation practice, make sure that you've got that ILS or basic life support with airway management training. There is lots of other training that you can have, but I'm very limited on time. So thinking around practical tips to stay inspection ready all year round. Ongoing compliance, like I said before, nobody expects that unannounced visit from inspectors. Be proactive rather than reactive. Look at the CQC Mythbusters, some really useful information on there, and they are updated at regular intervals. Read reports, be nosy, have a look at the latest reports that have come out and see if there are any that are non-compliant, why they weren't non-compliant. Communicate with your team. Keep up to servicing with your equipment and develop some good habits. So have the oversight of your recruitment, have the oversight of your training, and write it down. Evidence, evidence, evidence. If it wasn't written down, it didn't happen. That's always one of the sayings at CQC. So make sure that you have that evidence there. Remember, if you have a compliance system, it is an aid. That alone does not make you compliant. It is an aid. So make sure you understand what is expected of you as a provider, and you don't heavily rely on that compliance system as an aid. You use that as an aid rather than, I've got that, I'm fine. Finally, I promise, I know I've spoken for nearly 1 hour, but at the end of the inspection, your factual accuracy check. So you will have a draft report that's sent via email. Again, make sure that your registered manager nominated individual email address is up to date, because that's where you're going to be notified of this draft report. You'll have 10 working days to respond. And if you make no changes and don't respond, it kind of automatically rolls over. So it really is worth doing. You should and can check for typos, any incorrect information. As an inspector, you actually end up doing quite a lot of inspections, and it can blur the line a little bit. So make sure that you look and say, actually, no, I had 4 dental nurses instead of 14, for example. There could be typos. Inspectors are human after all. So make sure that you do check that. You can include any additional information which you feel may be considered. And remember, you are responsible as a provider for making sure that the responsible person has checked the factual accuracy of the draft report.
Someone's asking here, it's difficult taking cleaning products up and down the stairs at the end of the day. Can they keep them in the surgery?
Risk assess it, follow your COSH procedure. As long as they are, well, you need to really, dependent on what the cleaning product is as such, because your COSH procedure will likely say that they need to be locked away. You can certainly use them in the day, because it's unlikely that a patient will be left in the clinical room without supervision. So really, you're just thinking of those extreme circumstances where someone would take that, and those extreme circumstances sadly happen. So as long as yeah, that's what I'm thinking. Yeah, so as long as people are supervised, then yes, you would likely be able to keep them. CQC, and thinking of myself in own experience, you need to be practical, don't you? You know, it is about being practical as well. So yeah, I would refer back to your COSH risk assessment, what your own policy states. But yes, I would say that would be deemed appropriate, and then you could consider maybe locking it away at night once you've finished using it.
Just one more question, I think, Jodie, before we let you go. There's a question here about long-standing clinicians without references.
Risk assess it. That's what I would do. And on that risk assessment, I would probably deem that more of a low risk now. They're long-standing clinicians. Hopefully you've got everything else for them, but I would just put a risk assessment in place to say you are well aware that they haven't got the references. You've attempted to get the references. So hopefully when they started, you attempted to get them, and that there is a low risk there, but you are aware of the risk.
Brilliant. Thank you so much, Jodie. Thank you for all your help and advice. I'm sure everyone's found it really interesting. So thank you so much for joining, everybody. Bye-bye now.
Thank you.